So what we are going to be talking about is essentially nerve reconstruction in close traction injuries of the brachial plexus. I'll be dealing only with post-traumatic lesions, not birth palsy, which are an entirely different situation. Plus, as I had spoken to Jorge earlier, I plan to speak mainly about what I do in a primary situation. That is, the patient coming to me in a reasonable period of time where nerve reconstruction is likely to give a successful outcome. Uh, the cases which appear late, or where a primary reconstruction has failed, or other more difficult situations, I have excluded from this talk because it is already a huge file in my computer. So here goes. I would like to start with a basic outline of how each type of injury is going to be dealt with. So the overall, in the strategy of management of close traction injuries of the brachial plexus, we are going to talk about the diagnosis, how we arrive at a diagnosis that this is an injury that warrants surgical exploration and reconstruction. What is the plan of action in each situation? How do we achieve the desired target? How long it takes for the muscles that are targeted to appear, and when or how secondary orthopedic operations can be applied to optimize the outcome so that the limb becomes useful. Please remember, we are talking about the brain and spinal cord being disconnected from the upper limb by disruption of the communicating spinal nerves. So the diagnosis is largely on the history and clinical evaluation. I do not rely on investigations in order to make a decision whether I should wait or should I operate. So if there is a history of an injury at a high velocity, now in terms of traction, close traction on the brachial plexus or on peripheral nerves, we are talking about the body being at a speed greater than 30 kilometers per hour at the moment of impact. So it cannot only be if there is a collision between two vehicles, it is not only the vehicle in which the patient is traveling, but the other vehicle with which he or she collides, or at the speed at which he hits the ground. The associated fractures of the upper limb or the other limbs, the presence or absence of vascular injury, are indicators of the severity of the injury. It is unlikely that if there is an extensive deficit and a vascular injury, the nerves will have just suffered a mere pulling and will recover on their own. It is extremely unlikely. So these are all pointers towards which guide me towards attacking the patient surgically. Also, if we have also to apply a bit of logic, if within a reasonable period of, sometimes it happens that the patient just falls off a two-wheeler and stands up with the arm completely paralyzed. Now, do we directly jump to a conclusion of all 5 roots have got seriously injured? So if there is no spontaneous recovery at all within a reasonable period of time, please remember, a mild injury to a nerve is going to recover within hours and days, not weeks and months. So at least the proximal muscles or the nerves which have escaped injury should wake up and reveal themselves in terms of returning motor function within a reasonable period of time. And if that doesn't happen, then it warrants surgery. The occasional, now most of the patients that come to me have already undergone an MRI. So it's not my choice actually to investigate the patient with an MRI in order to make a decision whether I am going to operate or not. But if there is an evidence of preganglionic or root avulsion injuries, as I'll go on to talk, in the MRI, there is absolutely no purpose in waiting, because the MRI is fairly sensitive and specific to locate preganglionic injuries of the supraclavicular brachial plexus. I do not recommend depending on electrodiagnostic studies. I know that during our orthopedic training or during our medical training, we were taught to investigate nerves on the basis of electrodiagnostic studies. But I have not found them useful in making this very major decision whether to wait or to operate. So occasionally, very, very occasionally, do I rely on specific questions being asked to the person who does the electrodiagnostic study, and I base my decision to operate on that. In any case where there is a deficit which you are planning to reconstruct, you must first satisfy yourself that the place where you suspect the nerves to be injured are that those nerves are actually injured, and the injury is such that can never recover on its own. It is only after you have satisfied yourself on that point can you plan reconstruction. So complete exploration of the injured brachial plexus at the location that we suspect the injury to be is non-negotiable. The suitable reconstructive procedures are decided based on the points that I will talk about soon. But that is only done after complete surgical exploration. Now, what do we mean by nerve reconstruction in terms of when we are talking about brachial plexus? What we are trying to do is re-establish the brain's control on the paralyzed upper limb. So it obviously the nerve on the proximal side should be surely functioning. Now, under anesthesia, none of these nerves are working, obviously. So the decision about which nerves will be functioning or are likely to be functioning is made on clinical examination before surgery. And their integrity, anatomical integrity, is confirmed during the surgical exploration. Only after satisfying ourselves on both these points do we rely on that particular donor nerve, if you might call it that, to connect it to suitable target nerves so that the conduit will act as the method whereby the axons on the proximal side will grow towards the target muscles, and at a certain stage will re-innervate them so that the patient will be able to control that muscle voluntarily all over again. Of course, we don't experiment. We apply techniques which are known to work. And we must be aware of all available techniques and which are likely to work in a given situation, even before we embark on the surgical exploration. This is again a non-negotiable part of brachial plexus reconstruction. We must be aware of all possibilities and the success rate of each before deciding on which method to use. We should not try and succumb to the temptation of doing the simplest technique that one is aware of, or the one that one has learned in the last cadaveric course that we attended, and rely on that as if one nail fits all. That doesn't happen. One must educate oneself completely even before doing your first case. So we know that the nerves, when they ends, we examine the nerve ends under the microscope, the proximal functioning end and the distal non-functioning end both look almost identical. We do not have electron microscope during the surgery. So what we wish to do is make a watertight repair by approximating the epineurium on either side to each other, so that in order to hinder escape of growing axons and the growth of the axons along the degenerated nerve distally, so that it eventually reaches the target muscle. This is absolutely basic. And whenever there is likely to be tension at the repair site, we try to interpose cables of cutaneous nerve grafts, which are sufficiently laxly placed so that they serve to conduct all the growing axons towards the target muscle. But we must remember that at each repair site, there is a 30% reduction in the number of growing axons. So that eventually, if the proximal donor stump is not providing an adequate number, what will reach the eventual target after a greater amount of time, factoring in a month, a loss of a month at each repair site, it would mean that fewer axons will reach the target muscle after a greater amount of degeneration time. And therefore, the likelihood of return of function automatically decreases. Now, this is particularly true when we are talking about function distal to the elbow, and which has brought about a change in our attitude to accepting what was considered a no-no for 50 years. Since the mid-1960s, we were told that we should not mobilize the nerves because their ends might lose vascularity, and keeping the repair under some sort of tension ruins the possibility of getting an outcome. It has been found that outcomes distal to the elbow are distinctly better when one opts for direct repair rather than nerve grafting. And I will talk about that as I go on. Now, what is the objective of the nerve reconstruction? We want to restore the ability of the patient to, please remember that this is a limb which is hanging flail from the shoulder. The patient doesn't even know where it is. It is blind. It is insensate. Now, in such a situation, he has to constantly hunt for it by looking for it where it is, and then trying to grab it with the other hand and keep control on the paralyzed upper limb. So if we can re-enable him to place the arm in space at a place where he can see it, then he can guide that arm to help him in daily activities. So obviously, when we are doing reconstruction in the neck, the muscles of the shoulder and elbow are more amenable for re-innervation, and automatically restoration of shoulder and elbow control is a low-hanging fruit, if you might call it that. But the function distal to the elbow is more difficult to reconstruct. Complex intrinsic functions are practically impossible from repairs in the neck in adults. Now, if the deficit is extensive and we can only re-innervate certain specific targets, it is obvious that after those muscles have got innervated, we might need additional operations in order to stabilize certain joints or to change the direction of the limb so that the patient can use the recovered function. On the other hand, in partial palsies, as I'll go on to show you, we can make the limb independent by nerve reconstruction alone. So let us come to the anatomy. The spinal nerve, as it emerges at the intervertebral foramen, gives a dorsal primary ramus which supplies the paraspinal musculature, and the rest of the spinal nerve, which is formed by the confluence of the rootlets dorsal and volar, which again are arising from the anterior and the posterior horns of the gray matter in the spinal cord. They join together at the intervertebral foramen. The dorsal primary ramus is given off, and the ventral primary ramus contributes to the brachial plexus. And the ventral primary rami of the C5 to T1 spinal nerves on either side are termed as the roots of the brachial plexus. This is a convention that is followed across the world. And when we are referring to roots of the brachial plexus, we are talking about the spinal nerves beyond the intervertebral foramina, the ventral primary rami. Now, these can suffer, the nerves as they emerge from the vertebral column can be subjected to a pulling force in a variety of ways, but the most common way is by a fall from a two-wheeler with the impact on the shoulder and the head and the shoulder being pulled apart forcibly at the moment of impact. We all know that 80% of the injuries that I see in practice are of this nature. Yet, rules are practically never followed, and there are suicidal people on the streets. We know that the nerves, when they are subjected to a pulling force, will eventually break. Once there is an anatomical breakdown of the nerves, spontaneous recovery is not possible, because they have been, the ends stay apart. Now, this injury can happen. This is very important. The most important structure that we must know is the dorsal root ganglion, which is seen in the dorsal rootlets as they traverse towards the intervertebral foramen. It is before the formation of the spinal nerve itself. So, an injury proximal to it will be within the spinal canal, and that is termed as a root avulsion or a preganglionic injury, because it is proximal to the dorsal root ganglion. It might be likened to the plug being pulled out of the socket. Now, you might think that, okay, if the plug has got pulled out of the socket, why not put the plug back into the socket? That has been attempted by our senior colleague, Thomas Karlstedt of Sweden, who eventually migrated to England and has retired in the recent past. He pushed this idea from the early 1990s for a long time and even published a book on this. But again, when we know that the lower roots are more vulnerable for root avulsion, putting them back blindly through the intervertebral foramen, hoping for a reconnection with the spinal cord, has not given any reliable results in the hand. So that particular pathway is no longer being employed. There has been this other publication from Egypt as well on the same topic, but again, with very little success. So we shall not be talking about that. So when there is a root avulsion, we do not have an option but to borrow nerves from outside the brachial plexus or use nerves which are ruptured in the interscalene area, that is distal to the dorsal root ganglion, and therefore post-ganglionic injury. What it implies is that the anterior horn cells have axons which can grow from the broken end and can be harnessed by reconnection to the distal target nerves in order with a sincere hope of regaining that distal target function. That hope is not there when we are talking about preganglionic injuries, as I've already told you. So now the deficit that we might see might be total. That is, the arm is just hanging from the shoulder. with complete paralysis of all muscles innervated by the brachial plexus, or it might be partial, which the partial palsies in the decreasing order of incidence might be an extended partial palsy. I'll explain what that implies later on. A C5, C6, the standard so-called Erb's palsy, but the a deficit limited to the shoulder and elbow, as we'll go on to see. An injury distal to the clavicle, which is an entirely different set of patterns. And finally, the least common is an isolated injury of the C8, T1 roots, which has been also termed as the Klumpke's paralysis. So, plus, I don't need to tell you that there is no medical treatment. There's no point giving medicines. There's absolutely zero point in administering steroids in the first few hours with the hope that the nerves will wake up. The physical therapy, if at all, is only useful for maintaining passive range of motion. The paralyzed muscles are going to lie flaccid, will get stretched out with time. So you might attempt to maintain the tone in the paralyzed muscles while awaiting the re-innervation from the proximal side by external galvanic stimulation. But I have tried that for more than a decade, and it only leads to complications of the skin through which you stimulate the muscle without any significant gain in the quality of the function restored. As I said, the role of the physiotherapist is mainly to maintain the passive ranges of motion, and that since the arm is insensate, the patient or his attendant can learn to do and keep the limb supple while waiting for re-innervation. Merely manipulating the arm cannot wake up the broken nerves. Physiotherapy is not a method of treatment of nerve injury. So we are again come to this: a deficit following an accident, velocity at the moment of impact greater than 30 kilometers per hour, a persistent deficit, and if there is an MRI, distinct signs of root avulsions. All these are indications for surgery. We want to restore the control of the brain and spinal cord on the paralyzed upper limb. Therefore, we harness growing axons from functioning nerves and direct them to the pre-decided targets. Now, for that, we must have viable proximal nerve stumps that retain their connection to the spinal cord and connect them by nerve grafts, so that it would be something like this. Or if there are root avulsions, we have to borrow from outside the brachial plexus. The most common that we utilize from outside the brachial plexus are the spinal accessory, which most often is not injured and innervates the sternomastoid and trapezius. I prefer to use it after the branches that supply the upper trapezius. Intercostal nerves, there are 12 on either side. We can take 3 or 4 with impunity, as long as the ribs are not fractured or there isn't a severe chest injury. In the presence of a phrenic nerve deficit, which often accompanies these paralysis, the harvesting intercostals, particularly on the right side, might be a bit risky. Finally, in terms of total palsies, the use of the opposite C7 is an invaluable component of our reconstructive strategy. So we'll start with our clinical cases. In my practice, almost half my patients are present with total paralysis, that is, affection of all 5 roots. Again, as I say, the diagnosis is clinical. The brain and spinal cord are completely disconnected. There might be ruptured roots, 1, 2, or 3 in the neck. The remaining two C8T1 are most often pulled off from the spinal cord itself. A very large percentage of my practice is dealing with avulsions of all 5 roots, which is a really challenging situation. So the limb lies by the side of the body. The patient has no control except using the opposite upper limb to guide it wherever he wants. He cannot undo the button on his unaffected side. And even removing the shirt becomes a very tiresome exercise. So if only the trapezius is working, that is, he can shrug the shoulder, the rest of the limb is flail, and there is a Horner sign. The Horner sign is it signifies an interruption of the cervical sympathetic outflow. It is got a high correlation with avulsions of C8T1 roots, particularly in post-traumatic situations. This particular case can be labeled as an avulsion of all 5 roots. On the other hand, if the root is ruptured outside the intervertebral foramen, most often it is the C5 or say maybe C5 and C6 roots which would be ruptured, whereas the remaining would be avulsed. In that case, the first branch of these roots, which contributes to the long thoracic nerve and innervates the upper slips of the serratus anterior, would remain intact, and therefore function might be elicitable in those slips of the serratus. So the patient again would have the trapezius working, but there is some ability to move the shoulder girdle forward. But that is not the way we examine the serratus anterior, because the rest of the limb is flail. We can't ask the patient to press against the wall as we test for winging, because the rest of the upper limb is flail. So what we have to do is cradle the arm in this manner and ask the patient to move the shoulder forward and watch where the inferior angle of the scapula goes. If the inferior angle of the scapula follows the chest wall and goes forward when the patient is moving the limb forward, it is an indicator that some portion of the serratus anterior might be working. Now, Tinel sign. Tinel sign is tested, as we know that the ruptured roots are largely the C5 and C6 roots at the intervertebral foramina in the interscalene area. That area is located at the posterior border of the sternomastoid, where the external jugular vein appears to be crossing the posterior border of the sternomastoid. In that acute angle inferiorly is where the one has to press. And the patient must indicate the shooting pain in the distribution of that ruptured root. It should not be only local tenderness. It should be paresthesia in the distribution of the C5. In this case, there were 2 roots ruptured. So one of them was bridged to the musculocutaneous, whereas the other one was directly repaired to the anterior division of the lower trunk, which I'll talk about. To reiterate this test, this is again you can see the inferior angle of the scapula moving forward. And of course, he had a total palsy with a positive Horner sign. My friend Jaime Bertelli has published on the shoulder protraction test for testing for available root stumps and the integrity of the serratus anterior, which looks like this. As you can see, that is the serratus anterior, the inferior angle of the scapula coming forward. Sometimes, in the presence of a Horner sign and a flail upper limb, there seems to be something else happening. And it is wiser to examine the patient lying down, where the scapula is held in place and glenohumeral function can be tested. So we can see here that the supraspinatus is working. Now, why was it not producing abduction while the patient was standing? Because it is a muscle that is only 2 finger breadths in size, and therefore cannot lift the entire weight of the upper limb while standing. But when the patient is lying down, the scapula is held in place against the bed by the patient's own body weight. All the force of the supraspinatus is being utilized to abduct the shoulder, and the integrity of the suprascapular nerve can be judged from this. So in this case, it was an avulsion of C7. We saw the Horner sign in the earlier video. And there was a rupture of the C5, C6 distal to the origin of the suprascapular nerve, while the C7, 8, T1 were avulsed. And that is what I found on surgical exploration. You can see the anterior and posterior divisions of the upper trunk here, the suprascapular nerve intact over here. These are the C5, C6 roots as they emerge. This is the phrenic nerve. This is the scalenus anterior. And these are the avulsed C8, T1 roots, which were dissected out via the deltopectoral dissection. Now, the pioneers who got together to who worked extensively on nerve reconstruction. Once it was realized that these nerves can be reconstructed, particularly after the publication of Milesi in the 60s, it took off in a big way, particularly in Europe and in Japan. And they got together with the leader being Algimantas Narakas, who formed the so-called Narakas Club. And they tried every new method they knew in order to restore function in the paralyzed upper limb. Brunelli had published on the use of the deep cervical plexus. There was methods of using the ruptured root stumps, the intercostals. And all these experience was very carefully tabulated and published in monographies of the group Tétur de la Main, that is the French Hand Society. The first edition was in French in 1990. The second edition was in French and English in 1995. They all concluded that they were agreed on systematic exploration, the techniques that I've already spoken about earlier. But they said that the main objective should be restoration of elbow flexion against gravity. Reinnervation of biceps is the most important function that we must regain. If nothing else can be regained, at least elbow flexion against gravity must be regained. They were agreed on the fact that function distal to the elbow was very of poor quality, and so they focused on shoulder and elbow. Now, most injuries are supraclavicular, and most often there are root avulsions. Therefore, if there are root avulsions, we must borrow from outside the brachial plexus. Now, that is neurotization. That is, we borrow functioning nerves from outside the limits of the 5 spinal nerves, and they are utilized for restoring certain specific functions. And this was encapsulated in an article by Narakas in 1984, where he spoke particularly about intercostals. That intercostal is just breathing in and breathing out. It is just an almost binary function, and therefore can be used only for one target. It is not logical to use one breathing set of nerves of 3 intercostals for elbow flexion and the next 3 for elbow extension in the same patient. So it is just not logical to apply a surgical technique that one knows in an illogical manner. In addition to the intercostals, there was the spinal accessory nerve, which was first proposed by the Japanese surgeons, and it was brought to Europe by Aliu. And then there were a variety of publications in Europe, particularly from Aliu, but also from Alno in Paris, talking about the use of the spinal accessory nerve. The largest series came from Bangkok by Panupan, who used the spinal accessory nerve as the only way of restoring elbow flexion, particularly in total palsies. So when I started practice in 1995, that is what I did in total palsy. And this is an 18-year follow-up of one of my earliest cases. The chances of success of, the connecting the spinal accessory nerve to the musculocutaneous inevitably involves interposition of a nerve graft. And therefore, you're taking a motor nerve in the neck, connecting it with a nerve graft to a mixed nerve below the coracoid process with a 11 or 12 centimeter nerve graft. And then it takes 14 to 18 months for the biceps to appear. So, and there is absolutely no way of following whether something is happening or not. There is no Tinel sign to guide us. So there has been a trend towards trying to do a direct repair using intercostals, and the outcomes of the two were compared in this publication of 1999. Seddon first spoke about cases done by Yeoman, where he connected intercostal nerves from the chest wall, bridged using non-vascularized ulnar nerve grafts to the musculocutaneous nerve. Direct repair came into vogue from the Japanese surgeons in the late 1980s. And the number of intercostal nerves needed for the musculocutaneous nerve was compared between 2, 3, and 4 by this particular publication from Gu in Shanghai. And they studied only 30 patients and were not able to differentiate, find a statistically significant difference between 2, 3, or 4 nerves. I personally prefer to use 3 intercostals for musculocutaneous. So again, we come back to detailed exploration of the brachial plexus, find the donors, and then use them with the biceps as priority. So which are the muscles which we want to regain? Primary, of course, is the biceps. Then, of course, control of the shoulder by the rotator cuff, for which the suprascapular nerve is a suitable target. Then I prefer to add the pectoralis major. Currently, we are able to reinnervate the triceps in a consistent manner. And finally, function distal to the elbow is mainly related to forearm flexors. There is a hope for finger extensors, but we are not able to produce consistent results just yet. And then we must do secondary procedures to augment the utility. So when there is a total palsy, my philosophy is to use everything that I have in one major operation. Now, the targets are pre-decided on the basis of the age and the delay since the accident, and the outcomes of intercostal musculocutaneous being affected by these two parameters. I have published it in a large series of cases. So obviously, in a person older than 35, this is an arbitrary line that I have drawn, the proximal functions are more likely to be reinnervated. So I focus on stability of the shoulder, maybe some abduction, and pectoralis major, and elbow flexion. So this patient had a tree branch fall on his shoulder and had a total palsy. This was the reconstruction done, spinal accessory to suprascapular, intercostal to pec major and musculocutaneous, and C5 was bridged to the posterior division of the upper trunk. This was the result at 16 months. and he never came back for any secondary surgery, but did turn up for follow-up after 9 years, and the function stayed the same. This patient suffered an injury 54 years of age at the time of the accident. It was a conveyor belt type of industrial accident affecting all 5 roots. The C5 was bridged to the posterior cord, and the remaining reconstruction was like I showed earlier. And secondary surgery in the form of derotation of the humerus and wrist fusion was done, which allows the patient to place the arm in space and control the paralyzed upper limb. I prefer to add one intercostal for the pectoral now, which I started in February 2009. The pectoral branch that I use is located at the medial border of the pectoralis minor, accompanying the thoracoacromial vessels. And the third intercostal was used in a series of more than 250 cases to innervate the pectoralis major. And this is the outcome again. He was 42 years old at the time of surgery, elbow flexion from intercostals, shoulder abduction and external rotation coming from the spinal accessory to suprascapular, and innervation of the pec major on straining and deep inspiration can be seen in this video at 3 years follow-up. In younger patients, on the other hand, I prefer to add hand. So how do I do hand? The shoulder and elbow can be dealt with from the nerve transfers described earlier, and we can use ruptured root stumps when they are available by bridging them to the medial root of the median nerve. This was the traditional reconstruction that I did before 2013. And this girl was operated surprisingly at 9 to 10 months after the accident, and yet she was only 4 feet 10 inches tall. She did regain good function at the shoulder and elbow, and this sort of feeble finger flexion, which was augmented by the wrist fusion. But when there are avulsions of all 5 roots, we have got no recourse but to borrow from outside, and particularly the opposite brachial plexus if you want hand function. Now, for that, the publication by Wang Shufeng in 2013 is the most significant, because he erased our thoughts of using nerve grafts from the opposite C7, which consistently gave very poor results in my hands, to direct us to do a direct repair by moving the C7, pivoting at the bony margin of the intervertebral foramen, passing it by a pre-spinal route, which is the shortest way to reach the injured side, and connecting it to the mobilized lower trunk. And in addition, phrenic nerve to the posterior division of the lower trunk, and the spinal accessory to suprascapular for triceps and the rotator cuff respectively. With this, he was able to achieve what is considered a dream by all brachial plexus surgeons, that is independent prehension.
Still flow. There was no issue there, luckily.
Independent prehension in the paralyzed upper limb. I visited him in October 2013, soon after he had published this article, and got to know a bit about the method of achieving this sort of function. I went with my team of surgeons from India. Now, the strategy proposed by Wong is a comprehensive strategy encompassing the shoulder, that is by the rotator cuff, elbow flexion and elbow extension using the opposite C7 and phrenic nerve respectively. Finger flexion is targeted by the direct repair of the contralateral C7, and finger extension, if possible, is from the phrenic nerve to the posterior division of lower trunk, direct repair. Now, although in some cases we did get finger extension, that has not proved to be beyond 4% of all the operations that we did. And we have moved on to an alternative path when there are ruptured roots, but that is a subject of another talk. Now, what we mean by mobilization of the lower trunk is by pulling it up, isolating it in the neck, and mobilizing it. The length of the contralateral C7 is going to be limited. It is going to reach only a particular position in the as seen from the affected side. So we must mobilize the injured lower trunk to try and reach it. Once we approximate it, the growing axons along the medial cutaneous nerve of the forearm, which has been divided in order to mobilize the lower trunk, would otherwise be wasted. Therefore, we harness those to innervate the biceps in addition. So the contralateral C7 serves to innervate the finger flexors as well as the biceps. Now, in order to achieve all this, obviously we must not directly go to the deltopectoral region, but to enter this messed up area where the trunks are lying bunched up in the inferomedial part of the posterior triangle. Now, in order to achieve this sort of disentangling of these broken ends, we have to start by locating the suprascapular nerve, because that is the readily identifiable nerve emerging from the upper trunk, even when it is lying on the inferomedial part of the posterior triangle. So the omohyoid, which is inserted on the superior border of the scapula, is a guide that I utilize to locate the suprascapular nerve, as it is traversing towards the suprascapular notch. The suprascapular notch is further lateral to the insertion of the omohyoid. So once the superior border of the scapula is identified, one can locate the suprascapular nerve. And that, once it is located, one should not immediately apply a loop on it. One should dissect along it in order to reach the upper trunk, and then further medially to the broken ends of the C5 and C6, which are eventually freed in this manner. It is only after that dissection is completed and the upper trunk is everted out can we visualize the middle trunk. And a similar process is followed to get the middle trunk out of the way, which will then reveal the curled up lower trunk in the inferomedial part of the posterior triangle. And again, the dissection proceeds so that we get right to the broken end. Please remember, we are not going to attach the contralateral C7 to these broken ends, but they will serve as guides to ensure that the trimming is just about adequate to reveal healthy fascicles. If we go directly to the deltopectoral region, we might lose a centimeter or two, which would then eventually militate against a direct repair. So after all that dissection, we divide the pectoral branches in the deltopectoral region. The medial cutaneous nerve of the forearm is divided. Which will allow a further proximal mobilization. We must get enough mobilization so that with the arm adducted, the end should reach across the scalenus anterior on the affected side, because that is where the opposite C7 is going to reach. In the beginning, one felt the need to shorten the humerus in order to ease the tension at the repair site. The tunnel is made on the surface of the longus colli behind the esophagus. It is only after all these maneuvers that we are able to achieve a direct repair in this way. The pectoral branch that comes from the opposite middle trunk is also harnessed via a nerve graft cable and is again directed towards the biceps. This was the first case I operated by this technique as soon as I came back from China. And as it happened, she gave my best ever result. The rotator cuff function had come from the spinal accessory, elbow flexion from the contralateral C7. The triceps came from the phrenic nerve transfer. After wrist and radial nerve fusion, we could see that there is finger flexion and finger extension coming from the phrenic nerve transfer. And the combination of all these positive outcomes resulted in the patient being able to manipulate objects in space without any visible participation from the opposite upper limb. So this sort of, when sometimes we are not able to reinnervate the posterior division of the lower trunk. So most of the focus is on the rotator cuff, elbow flexion, wrist and finger flexion. Triceps it being not being possible to innervate the triceps. You can see that without any significant gesture on the opposite side, the patient can flex the wrist and fingers, pulp to palm 0, avulsion of all 5 roots. And when he is flexing the elbow and the wrist, the opposite upper limb is not being engaged. So he can do any other activity even while keeping the fingers flexed or the elbow flexed, so that he can utilize the regained function in this way. The way he's handling the bag is entirely from the contralateral C7, and he's still using the opposite upper limb to fill the fruit in the basket. And he is able to carry that weight with the fingers flexed. The fingers don't give way. A similar result again in the avulsion of all 5 roots. Pulp to palm 0 after secondary surgery. Another patient where triceps could be reinnervated. So rotator cuff, elbow flexion from the opposite C7, no visible gesture on the opposite side. Wrist and finger flexion from the opposite side. Triceps from the phrenic nerve. When he is flexing the elbow, wrist and fingers, the opposite upper limb is free. And he can manipulate objects independently using that upper limb. And this is not being an isolated result, as you can see, another patient. So in young adults, I would advocate a sincere effort to try and achieve this sort of target. Sometimes you are not able to achieve this sort of target. So here the rotator cuff did get reinnervated. He was 30 years old when I operated him. The elbow flexion from the C5 nerve graft did not seem to be very promising. And the wrist and finger flexion from the opposite C7 could be was reinnervated, but again was of no use to him. And the triceps was innervated and was firing every time he strained because the phrenic nerve was firing. So I did a triceps to biceps transfer and a wrist and radial nerve fusion and an FCU transfer to the EPB, which restored good elbow flexion right away. And following a derotation osteotomy of the humerus, he was able to control the limb in a far better manner. And as you can see, although the finger flexion is feeble, he is able to activate it without a visible gesture on the opposite side. And he is able to move objects to a certain extent using that paralyzed upper limb. So these more superior results of direct repair were published by us, by our team in 2017. The same concept can be utilized for ipsilateral ruptured stumps, root stumps, in order to regain distal function. Now, this patient came with a total palsy. The poorly treated fracture of the upper end of the humerus dissuaded me from trying to innervate the rotator cuff. So I used the ruptured C5, C6 for direct approximation to the anterior division of the lower trunk, combined with phrenic nerve transfer to the posterior division of the lower trunk and spinal accessory being bridged to the musculocutaneous nerve, which at 2 years and a few months had provided elbow flexion, wrist and finger flexion, and elbow extension from the phrenic to PDLT. But the shoulder was still out of his control. The wrist and finger flexion was fairly strong from the C5, C6 repair. There were two roots contributing. So following a shoulder fusion, wrist and radioulnar fusion in pronation, he gets pulp to palm 0. The thumb is in a good position and he is able to control the limb well. And you can see that the hand is in a good position.
Bueno, ¿vamos a subir o no? ¿O más tarde?
Sí, vamos.
And as I said, the shoulder fusion worked very well because the serratus was working and the biceps and triceps were both functioning from the reinnervation. So this use of the ipsilateral ruptured roots for innervation of the lower trunk was published by us in 2020 in the beginning of COVID. Now from here I'll go on to the partial palsies. Jorge, I can continue, can I not? Jorge, are you listening? No. Anyway.
Yes. Yes, Anil.
Right. So I'm going on to C5, C6 palsies as opposed to extended because I would like to mention Oberlin's name at this stage and not later on. Now, as you can see from my pie chart, it is less frequent in my practice than extended partial palsy, yet I'm going to move on to C5, C6. The deficit is limited to the upper two roots, and therefore it is only loss of abduction external rotation, that is loss of rotator cuff, deltoid and teres minor. Biceps brachialis, brachioradialis. Please remember the brachioradialis will also be denervated when it's a C5, C6. And there might be some loss of latissimus dorsi teres major. So this is the deficit. The patient would present like this, that he has got no shoulder abduction. The arm stays adducted because the pec major is intact. The elbow stays extended because the triceps is working, but there is no elbow flexion. The wrist is stable because ECRL, ECRB preserve innervation, and the distal median ulnar and radial functions are preserved. The pec major is retained. So also the latissimus dorsi. The triceps function is retained. And the distal median ulnar and radial functions will be retained. Particularly, what is important to note is the integrity of the flexor carpi radialis, which helps to differentiate this from the extended partial palsy. As I said, exploration is non-negotiable. We must confirm our clinical diagnosis. You can see the C5, C6 at the intervertebral foramina with the crossing phrenic nerve. The C6 was avulsed, the C5 was ruptured. Now, historically, there is a publication by Darakas in 1984 where he says that a preganglionic injury of C5, C6 is still an insoluble problem in his practice. and he did not have a satisfactory answer for restoration of elbow flexion. Please remember, in those days in Europe, direct repair of the intercostals to the musculocutaneous was not done. He did use nerve grafts. He used 4 intercostals, but bridged with a nerve graft to the musculocutaneous. The transfer of a portion of the radial nerve for the deltoid was already present, but that was again with the nerve graft. And the spinal accessory was used for the rotator cuff. Barely 7 years later comes the person who is most well known in brachial plexus circles, who thought that with the C7-8T1 completely intact, can we not borrow axons from those functioning nerves without downgrading the hand function and try and restore elbow flexion? Which led to this idea of harvesting fascicles from the ulnar nerve, which would surely contain only C8T1 and therefore definitely intact, and approximating them to the nerve to the biceps directly for restoration of elbow flexion. This revolutionary thought came from my teacher and mentor, Professor Christophe Oberlin of Paris. My association with him started in 1992. And when I came from Italy to attend his cadaveric courses on flaps in Paris. And that association, after a year of working with him in 1994, continued over the years. He visited Pune and then went on to Nasik in India for a conference at my invitation. We published 2 books together. Even enjoyed holidays, family holidays together. And I had the ultimate honor of being co-faculty with him in Bangkok in 2018. As late as last year in May, Jorge and his daughter and I were together with Christophe and his wife at his home in Paris. So he first presented this idea 7 years after Narakas said that he didn't have an answer. He presented this idea at the Narakas meeting in Lausanne and then published the first series of cases in 1994. For a long time, people used to focus only on using the ulnar nerve because the ulnar nerve surely contained the intact C8T1 fibers. Ability of the median nerve to add to this set of donor axons was proposed and published by McKinnon 9 years later. And since then, a double fascicular nerve transfer has become the benchmark for restoration of elbow flexion in partial palsies. Now, innervation of the deltoid, as I said, has been known for more than 100 years because of Stoffel's work in 1913. But it was really popularized by our friend from Bangkok, Somsang Lee Shabangwong, who published on the use of the long head branch by the posterior approach to innervate the deltoid. But I do know for a fact that my other friend and very dear friend, Jaime Bertelli, was working on the same topic, and he published just a few months later in 2004. So to me, the triceps to deltoid nerve transfer should actually be considered attributed to both of them. But apart from that argument, there is absolutely concurrence among all brachial plexus surgeons across the world that a combination of these nerve transfers in a C5, C6 produces this sort of magnificent function in a consistent manner. So we might say that this problem of C5, C6 root avulsions, we have a satisfactory solution for it. I'm letting this videos run because I want, this is all I'm going to talk about C5, C6. We really don't need to mention it again. You can see that there is no brachioradialis, therefore the elbow flexion is entirely from the biceps and brachialis. And you can see the excellent deltoid. So we come to the more interesting topic of the extended partial palsy. Here the function, loss of function is not limited, as I said earlier, to the rotator cuff and deltoid and teres minor and the biceps brachialis and brachioradialis. But in addition, there is some loss of pectoralis major, some loss of latissimus dorsi teres major, incomplete triceps, loss of independent wrist dorsiflexion. ECRL, ECRB are almost always denervated in these cases. And the clue to the existence of this extended palsy is the absent flexor carpi radialis. So this patient presented with this sort of extended palsy. There is some distal function. He had a laceration across the posterior triangle, but the spinal accessory nerve was not injured in it. The hand function was so poor, but the median and ulnar functions could individually be elicited. And once the wrist was stabilized in the neutral position, the finger flexion was fairly strong. He had preserved intrinsic function. The MRI showed a preganglionic injury of 4 roots. The X-ray showed a raised left dome of diaphragm, which indicated a phrenic nerve paralysis as well. So I did a spinal accessory to suprascapular, a double fascicular nerve transfer for elbow flexion. Now please remember, the hand, the shoulder and elbow were flail, and therefore the hand function produced a weak grip strength, but that did not deter me from relying on a double fascicular nerve transfer for elbow flexion. And I combined that with a nerve transfer, which is described by my friend Jaime Bertelli, for reinnervation of the ECRB, which gave good shoulder abduction, good elbow flexion, but no external rotation. As you can see, this the deltoid is not functioning. It is just like a Popeye, like a muscle lying there. If you compare it to the opposite side, it was far lesser. No external rotation. So I did a derotation osteotomy of the humerus, which immediately brought the limb into a much better position. And at long term, his function was retained. But when there is a ruptured root stump of the C5, then that can be harnessed to the posterior division of the upper trunk to get the deltoid as well. And here external rotation comes. So what is the difference between the two reconstructions? The nerve transfers was still the same. Why did I get external rotation in this case but not in the earlier case? Same age group. So I felt that the difference was the preserved innervation of the serratus anterior from the ruptured root, which led me to embark on a project which systematically innervate the long thoracic nerve after having confirmed the avulsions of the C5, C6, C7. That is, the non-functioning long thoracic nerve is confirmed in the neck first, and then I systematically include innervation of the long thoracic nerve via the axillary incision. So this patient had an extended partial palsy, absent shoulder abduction, external rotation, absent elbow flexion, apparently preserved distal functions. You might think that the wrist is stable, but the pec major was partly denervated. The clavicular head is not contracting. Only the sternocostal head is working. The latissimus dorsi was weaker than the opposite side. The triceps was mainly the long head. Flexor carpi radialis was missing. This was the palmaris longus and FCU working, but the FCR was absent. And independent wrist dorsiflexion was absent. The patient was using the finger extensors in order to dorsiflex the wrist. There was no contraction in the mobile VAD at the elbow. Surgical exploration showed the avulsion of C5, C6. The C7 appeared intact but was not stimulable, did not give any response on stimulation, and even the long thoracic nerve did not give any response. So it was an avulsion of these three roots: rotator cuff, double fascicular nerve transfer for elbow flexion. This transfer, as described by Bettelli in 2012. Mine is the only other series published of this particular technique, which I published at the beginning of COVID. Using the anterior interosseous nerve to innervate the ECRB. And I added what I call the Bhatia transfer, but it's not essentially a Bhatia transfer. It was published by McKinnon earlier. And Doi has published one case report in 2010. My first case was in 2008. So the combination of this nerve reconstruction produces excellent shoulder control, excellent elbow flexion, good independent wrist dorsiflexion. You can see the contraction of the ECRB now. And he gets full external rotation. And this is, of course, not an isolated incident. This is a reproducible type of restoration of function achieved in C5, C6, C7 avulsions. Abduction remains limited to 30 to 40 degrees, but the patient gets full external rotation, strong elbow flexion, and good independent wrist dorsiflexion. And therefore becomes functionally rehabilitated without any need for a secondary tendon transfer or secondary reconstruction. So we come to the biggest, my most favorite set of pattern, that is the infraclavicular injuries. This is a very challenging sort of situation where the mode of injury would be different from that noted. It's not always a motorcycle accident, but a variety of methods of injury. I've even seen an injury where the patient was tied up after organophosphorus poisoning, and while thrashing around in the bed with the hand tied to the cot, and the chest being immobilized by another strap, the musculocutaneous nerve ruptured in the axilla. A fall in abduction, external rotation, is more likely to cause an infraclavicular injury. So the set of fractures that are seen with such patients are different. There would be a surgical neck of the humerus, lateral end of the clavicle, lateral, the acromion might be fractured, the scapula might be fractured, or there might be a fracture dislocation of the shoulder. As you can see in abduction and external rotation, the musculocutaneous nerve is tented over the protruding head of the humerus, while the axillary nerve is the only one which crosses obliquely across the protruding head of the humerus. Therefore, these are the two nerves which are most often vulnerable to pulling force when the patient falls in this way. So we are talking about injuries distal to the clavicle, and therefore the divisions, cords, and the terminal branches. The nerves that are vulnerable to injury are those which have a short distance between the emergence from the brachial plexus and entry into the target muscle. That is short segment between two fixed points. These are most often the suprascapular. As it emerges from the upper trunk and goes into the suprascapular notch, the impact pushes the scapula, and therefore the suprascapular notch, and subjects the suprascapular nerve to traction. Musculocutaneous and axillary, I have already told you. The lateral and posterior cords are most often affected. The medial cord, median and ulnar nerves are much less often seen in our practice. So the injury would affect the musculocutaneous and axillary, the suprascapular, and the radial nerve branches to the triceps. Sometimes the radial nerve itself might be ruptured. So the deficit, as I told you, if it is a suprascapular nerve, the axillary nerve, musculocutaneous, it would still be loss of abduction, external rotation, and elbow flexion. So how do we differentiate this from a supraclavicular injury? In the beginning, since certain muscles survive, we might miss the injury, and it requires really detailed clinical examination to find out where the injury is. So let us see this patient. He came with preserved abduction and external rotation and preserved elbow flexion. So what's wrong? But when you examine him closely, you see that elbow flexion is being produced entirely by the Chandler effect and the brachioradialis, and there is no contraction of the biceps. Whereas if you see the opposite biceps, this is how it looks. So he had an isolated rupture of the musculocutaneous now. So we must, I would strongly recommend detailed clinical evaluation.
No te metas, que no se meta.
After having examined in detail, you determine which muscles are absent, which are the corresponding nerves, and then we stand back and evaluate whether such a combination of lesions is known or is it possible. Now, this is where the role of EMG comes in. Since I showed you that the muscle bicep doesn't seem to be working, but how do I know that is definitely not working? So an EMG of the biceps would be of value in such cases. So the prescription has to be specific. One must not write EMG NCV upper limb. We have to say we are looking for a deficit in the musculocutaneous now, and therefore the EMG of biceps is demanded. Since all the nerves have been subjected to traction at the same time, but only there is deficit in only these territories, it is possible in the absence of a very violent injury that there might be spontaneous recovery. Therefore, there is a possibility of return of biceps, but we wait only up to 2 months for the biceps. Similarly, if there is an isolated deficit in the deltoid, there might be spontaneous recovery. If it is a mild type of injury, the recovery might appear as long as 4 to 6 months after the accident. So one should not be in a hurry to jump to a nerve transfer to reinnervate a deltoid in an isolated axillary nerve injury. The structural damage to the nerve must be confirmed by surgical exploration. Role of MRI here is very low. It can only, this same mechanism can also affect the rotator cuff, and that might be responsible for the absent rotator cuff function and not the suprascapular nerve. Therefore, an MRI might be useful to locate this injury. but it does not contribute in any way to our decision whether to wait or to operate. We must know the common patterns that are seen, and if there are associated fractures of the shoulder girdle and an axillary artery injury, one must suspect a severe injury to the affected nerves. So there might be a puncture wound with a deep abrasion with a thrombosed axillary artery. You can see the ruptured axillary nerve next to it. Most often they have fractures in the ipsilateral upper limb. In my series, strangely enough, shoulder dislocations have not appeared so frequently. My personal series of infraclavicular injuries is now 200 cases, and only half of them, or rather only 8 or 10 of them were associated with fracture dislocation of the shoulder, whereas ipsilateral fractures were seen in more than 80% of them. Now, if the deficit is going to be musculocutaneous or the axillary, we now know that we can do a nerve transfer for deltoid, or we can do a double fascicular nerve transfer if the medial nerve and ulnar nerve are intact for restoration of elbow flexion. So, but if we are dealing with a purely infraclavicular injury, we do have a valid proximal stump, which is the nature's dedicated path for elbow flexion. Therefore, isolation of the musculocutaneous nerve and bridging it from a healthy stump proximally to a healthy stump distally for the musculocutaneous nerve itself, without sacrificing a fascicle from the intact median ulnar nerves, also works in younger patients. Similarly, for the axillary nerve, I prefer to do nerve grafting in the younger patients. For radial nerve, we can use triceps. For triceps in particular, if the thoracodorsal nerve is intact, we can use that for the triceps. Else, one can use intercostal or nerve grafts from the posterior division of the upper trunk in the neck. And distal functions, I prefer to do tendon transfers, apart from ECRB, of course. So now let us look at the radial nerve. This patient presented with a wrist drop, but you could see that the lat dorsi was intact, the deltoid was working, but there was no triceps. And of course, the distal radial nerve function was not present. And I approached it from the axilla, traced the radial nerve proximally, and it was avulsed from the posterior cord. So here I did this transfer that was published by Jaime Vertelli, where the intact latissimus dorsi was sacrificed and the thoracodorsal nerve was connected directly to the radial nerve branches to the triceps. At the same time, I did my preferred tendon transfers for distal. The patient regained more than grade 3 triceps. And the tendon transfers gave the expected result. The palmaris longus to the rerouted EPL. This lady presented with a wasted deltoid, and she had suffered a fractured scapula. She was sitting on a two-wheeler as a pillion rider with her son, and she had a wasted deltoid, but there appeared to be some abduction while sitting. So I examined her lying down, and you can see the rotator cuff functioning. The axillary nerve was found ruptured below the coracoid process. distal to the origin of the thoracodorsal nerve. Given her age, I prefer to use a triceps to deltoid nerve transfer. And this was the outcome. This patient came with complete loss of abduction and external rotation of the shoulder. Now, the patient coming with a combined deficit of suprascapular and axillary, one might, wait a minute, I just have to go on. Yeah, this patient came with a complete loss of abduction and external rotation of the shoulder. Now, you might think that this would be a C5 avulsion, but that is only very uncommon. I've seen it only once in my life. But what is more often seen is the combination of a suprascapular nerve plus axillary nerve injury. Since the spinati were not working, therefore it was the suprascapular not working, deltoid and teres minor not working, the axillary nerve was disrupted. This is a combination that I've seen about 10 or 12 times in my career. In these cases, I'm most often afraid of the suprascapular nerve being pulled off from the rotator cuff itself. Here, I had dissected it from the front and I found a ruptured suprascapular nerve, went by the posterior approach, found the stump distal to the notch and connected a graft to it. So I grafted the suprascapular nerve and I did a triceps to deltoid nerve transfer for the deltoid. This is a 4.5-year follow-up. Since these are specifically targeted to the deficient muscles, the results are very satisfying. This patient came with absent abduction, external rotation, absent spinati, deltoid, teres minor, preserved biceps and brachialis. Preserved pectoralis major, absent latissimus dorsi, absent deltoid and teres triceps, and absent distal radial functions. So the patient had absent spinati, absent deltoid teres minor, absent radial function, absent latissimus dorsi teres major. Therefore, it is surely is suprascapular plus posterior cord injury. And accordingly, the surgical exploration is done. This was the posterior cord at the clavicle done by the deltopectoral approach. You can see the cephalic vein. That's the bifurcation into the radial nerve and the axillary nerve as seen there. And the end held superiorly is the broken end at the level of the clavicle after the confluence of the three posterior divisions. In the neck, the suprascapular nerve, the posterior division of the upper trunk, you can see the suprascapular nerve also ruptured, and the posterior divisions of the upper and middle trunks could be easily seen there. So I grafted from the posterior division of the upper trunk to the axillary and radial nerves, and I did a dedicated nerve graft for the suprascapular nerve. And in addition, for the distal wrist extension, I did a AIN to ECRB transfer. This patient has never come back for follow-up. He sent me this video on WhatsApp. Excellent restoration of shoulder abduction and external rotation and triceps. And you can see good independent wrist dorsiflexion with good contraction of the ECRB. He has never come back for a tendon transfer for finger extension. You can see the strong triceps even in the video that he has sent me. Again, this application of thoracodorsal to triceps, this patient had a wasted deltoid He had preserved elbow flexion from the biceps brachialis. The distal radial function also was preserved, but there was no deltoid and there was no triceps. Now, this is a very strange injury. The rupture of the axillary nerve below the coracoid process could be readily isolated. But in the axilla, one could see that only the radial nerve branches to the triceps were disrupted. The rest of the radial nerve remained in continuity. So I did a nerve grafting to the axillary nerve because obviously a triceps to deltoid was not possible. So grafting for the axillary nerve, although he was beyond 50, and I did a thoracodorsal to triceps. At 18 months, he had regained some deltoid and a good triceps. And during COVID, I was able to get this sort of video from him when he was isolated at home. This lady, now the importance of clinical examination is highlighted in this case. This patient seemed to have a C5, C6, C7. In fact, on the day of the operation, I had planned on treating it as a C5, C6, C7. And yet, there seemed to be some shoulder function. I thought that she was rotating the shoulder. So I examined her lying down, and you can see that the supraspinatus was preserved. So it was a posterior cord plus lateral cord injury, absent musculocutaneous, absent axillary, absent radial, absent lat dorsi teres major and subscapularis. So it was a posterior cord injury plus musculocutaneous. This is the ruptured end of the axillary nerve detected in the by the axilla, but I delivered it posteriorly. This is the ruptured radial nerve in the armpit. The dense scar at the origin of the musculocutaneous nerve. So I did a double fascicular nerve transfer for elbow flexion and nerve grafting for the axillary nerve and the radial branches to the triceps. The posterior division of the middle trunk was grafted to the triceps, and the posterior division of the upper trunk was grafted to the deltoid. Subsequently, now strangely enough, one doesn't usually fuse the wrist for distal functions, but here since I was not confident of the AIN transfer in this case, I did a wrist fusion and I transferred the FCU for finger extension. So this was the long-term follow-up, the elbow flexion from the double fascicular nerve transfer. This is the way I examine for a recovered deltoid. I support the arm in abduction, and you can then ask her to hold the position, and you can see the contraction of the deltoid. And this is the restored function in the triceps. She is not able to perceive it because it is lying behind her back, and when she relaxes the elbow flexion, the elbow extends. So she is not able to perceive it. You can see this is the range of abduction regained, the triceps, and this is the finger extension from the FCU transfer. And the thumb from the palmaris longus. So she is able to use that hand independently. Finally, we come to the Klumpke's palsy. We are right at the end of the talk. We are talking about the avulsion of C8T1 isolated avulsion. Here, proximal functions would be preserved. Triceps most often is preserved. Brachiodalis, ECRL, ECRB will be preserved, but the rest of the radial nerve function, that is extrinsic extension of the fingers and thumb, are most often absent. Sometimes, only in one case I have seen that the finger extension was preserved, but otherwise, most often the finger extension is absent. FCR is preserved, but the rest of the median nerve is not, is paralyzed. So you can see in this child, good abduction, good elbow flexion and extension. But when you check for the pectoralis major, only the clavicular head is contracting, the sternocostal head is not contracting at all. Elbow flexion is preserved, FCR is preserved, but rest of the median nerve territory is 0. Brachiodalis is preserved. And ECRL, ECRB. This patient did not have finger extensors. So ECRL, ECRB is preserved. They always have a Horner sign. And MRI indicates a preganglionic injury to C8T1. So here I prefer to do tendon transfers for the thumb and finger flexion, like so. Brachiodalis to FPL and ECRL to the FDP of all 4 fingers. This patient had finger extensors also working. So then nothing was required for the finger extensors. So tendon transfers provided closure of the fist and opening of the fist was already present. On the other hand, when finger extensors are not working, we prefer to use what was published again by Jaime Bertelli, very popular for tetraplegia, and also in these isolated cases of C8T1. In addition, I use the ulnarmost branch of the superficial radial nerve, which is intact, to innervate the dorsal cutaneous branch of the ulnar nerve, so that the ulnar border of the hand regains some sensation. So this patient had the typical plum case palsy. Tendon transfers and nerve transfers provided finger flexion, thumb flexion, and finger extension. Subsequently, I utilized the paralyzed FDS of the middle finger for a lasso operation to correct the hyperextension of the MP joints of the fingers, so that opening of the fist improved. Now, all this effort of 29 years has aged me in this way. So we chose Jorge, Alex Muzet, and Tarek El Gamal and I. We chose to start this to extend Jorge's activity of training new brachial plexus surgeons, which he is already doing in Mexico for so many years. We expanded that to an international school with, of course, our mentor, Piero Raimondi. And this was the first batch that came to us in 2018. This is at my hospital. This is when they visited Asyut in Egypt. This is the 2019 batch which had come to me at Pune. We got together the last time just before COVID in Barcelona. So I would encourage young brachial plexus surgeons to not get disheartened by early failures. Systematic examination, systematic surgical exploration, application of known techniques. If your own results don't match what is shown by the experts. Go to the places where the technique is performed regularly. Learn how it is done in a correct manner so that you do your patient justice. I thank you all for your attention. Jorge, wake up. Gosh.
Okay. Okay.
Hello,
Uh,
Jorge.
My dear Anil.
I hope I was clear in all the concepts that I wanted to deliver.
Definitely, you were. And as you promised, this was an extended, almost 2 hours lecture. And we still have 90% of the people that connected. So that's amazing. And everything is being recorded.
Oh,
So-
I'm very grateful. I hope you will give me the video.
Yes, of course. And there are some questions. I'm going
Please.
to tell you a couple of them. So you mentioned that we have the answer for C5, C6 nerve reconstruction, right?
Yes.
What about the hand? Are you happy with the hand? Or do you think the ultimate, function to grab something in control will be the hand prosthesis and 5 roots avulsion?
In all 5 roots avulsion, I would not dispute the superiority of the function shown by Azman using the B-bionic prosthesis. Certainly that for suitable patients and dedicated patients would be a much bigger step forward. The cost of the prosthesis, the weight of the prosthesis are things which technology will bring under control with time. The control of the shoulder and elbow will still have to be restored using the nerve reconstruction technique that we know. But yes, in suitable patients, the application of the prosthesis is a wonderful replacement for the contralateral C7, which is currently our benchmark for finger flexion.
But that finger flexion sometimes is not very useful, right?
It is most often not useful because the patient can't open the fist.
Yes.
So holding objects is still dependent upon the unaffected upper limb pushing the object into the palm. So you might say that it is just a video result of finger flexion, even though it is palm to palm 0. So yes, our efforts currently at finger extension, consistent results have not been achieved, and therefore independent use of the hand happens in very few patients of total palsy. And since they form the majority of our patients, it is a disheartening point. Maybe the processes is something to look forward to.
Beautiful. Well, my dear Anil, I really appreciate your lecture. We are here. Pónganse todos acá atrás, por favor. I'm going to show you my fellows that are here.
Let me just let me stop sharing first.
Okay.
How does one do this? Wait a minute.
Can you see
Zoom?
the?
No, I can't see. How do I come back?
Yes. Exit.
How do I stop sharing?
Okay, yes, exit. Sí, como pues tú eres el experto. Close your presentation then.
Okay, I'll do that. Yeah.
And there is a place that says quit presentation. So can you see all the group that is here?
Yeah. Yes. Yes, I can see them. Wow. You really have a dedicated following. I wish I had so many students.
Well, these are all friends.
Yes, but then they are our next generation.
And everybody is grateful for your effort and your lecture. And I'm happy that,
Can you see me now?
yes, I can see you
Yeah.
now. And this, I'm happy that you honor Christoph,
Yes.
mentor.
How can I not?
Yes, yeah, you're a very grateful person. And Christoph is such a wonderful human being and such a skillful surgeon and a
Yes.
really thinker.
All that I learned about respect for soft tissues and dissection close to the nerve was after my having spent a year with him. So that courage to do this completely independently in India when I had no one to guide me, that came from my time spent with him.
Great.
Of course, then the rest of it is all you know very well. We have to stick to it. We must not get disheartened and by initial failures and keep documenting everything. So I hope that the slides that I showed of the lesions were reasonably clear for the people who are listening.
Well, some pictures and videos were not very clear, you know.
I know you don't like iPhone. But I do all my own recordings. What can I do?
Okay. My dear Anil, well, we have work to do. We have,
Yes, I know. You carry on for your surgery. You are
we
getting
have 5
delayed.
cases in the morning, so
Right.
we're going to continue.
I really envy your practice. So I think I will enroll for your fellowship.
Well, you are welcome to join here our group in Mexico.
I will keep that in mind. The day I feel I want to migrate, I'll come to your home.
This is your home, my friend.
Thank you very
Okay.
much.
Okay,
Thanks.
have a great night. And thank you for everyone that was connected.
I hope you have a fruitful day. Bye.
Yes, bye-bye.
Thank you very much. Bye.
Thank you.